Welcome. In this video, we're going to continue our discussion of medical ethics, and we're sort of going to continue our discussion about ethical questions surrounding abortion, but in another way, we're going to be taking a new look at the question, because instead of asking the question whether there are reasons for or against seeing abortion as morally permissible, we're now going to ask the question, given that abortion is a controversial issue within medical ethics, what are we going to do about it? And a paper that addresses this controversy is actually a paper written by committee. It's a paper written by the American College of Obstetricians and Gynecologists, also sometimes known as ACOG. And they published a committee opinion. It was first published in 2007, reaffirmed in 2016. And this paper is offering ACOG's view on how to deal with the fact that abortion is controversial and that there are some healthcare providers who are not morally comfortable with providing abortion. So that's our plan for this paper, is we're going to look at the view of the American College of Obstetricians and Gynecologists. They are an organization that trains and licenses obstetricians and gynecologists in America. And they also do important work credentialing obstetricians and gynecologists. Now, broadly speaking, ACOG is a pro-choice organization, right? They have advocated for maintaining rather than decreasing the rights of patients to receive an abortion. They also think that providers should not be restricted in making decisions about whether an abortion might be appropriate health care for their patient. So in this paper, we're going to look at the question of what we should do about providers who morally object to abortion. And here's the big takeaway that I'd like you to get from this paper, is that ACOG thinks that provider integrity and conscience, those are worthy of respect and accommodation. But, and there's a big but here, it's that we should accommodate the conscience of providers only if patient autonomy and well-being are not sacrificed in the process. So here's the plan. We're going to look at some problematic cases that ACOG is concerned about. We're going to look at what we're really talking about, philosophically speaking, when we talk about somebody making a conscientious refusal. And we'll talk about the value of respecting conscience in healthcare. And then finally, we're going to look at some of ACOG's recommendations for limiting conscientious refusal. So without further ado, let's look at some cases. So these are some cases involving conscientious refusal on the basis of healthcare providers that involve a lack of access to care for patients. And these are cases that ACOG sees as problem cases. So in Texas, a pharmacist refused to provide emergency contraception to a sexual assault victim. And this pharmacist claimed that to provide emergency contraception, that is, a drug like Plan B, would be a violation of morals. In a similar way, they don't describe the reasoning behind the healthcare provider in this case, but a 42-year-old mother was refused emergency contraception, and because she was refused emergency contraception, she eventually ended up having to get an abortion, a situation that she was trying to avoid in the first place. In California, we find a case of a doctor refusing to provide intrauterine insemination to a lesbian couple. So we've got two women who are romantically connected. They want to have a baby together, but the physician who they go and see says they will not provide care for these women, and the paper says on the basis of the provider's religion and also their personal views on same-sex parenting. So apparently, even though the data that I've seen suggests this is not true, it seems that this physician maybe believed that same-sex couples cannot do as good of a job raising a child. That doesn't seem to be backed up by the facts, but that did seem to be the reason for the provider's refusal. In fourth case, we have a 19-year-old who is 10 weeks pregnant, and she's suffering from a pulmonary embolism. So when you have a pulmonary embolism, that's a blood clot which can affect your lungs in a way that could kill you if it's not treated. And it seemed that what was indicated in this situation, unfortunately, was that this woman needed to have an abortion in the process of getting her pulmonary embolism under control. Now, she was taken to a religious hospital. The religious hospital said they did not provide abortion to patients. And because of this, this young woman had to be transferred via ambulance to a different hospital to receive an abortion and also to receive care for her pulmonary embolism. So ACOG, in this instance, thinks that this is a situation where we have conscientious refusal going too far. That is, they think that while conscience does have its place, it can't go so far to stop people from receiving the care that they want from healthcare providers. So what are we talking about when we talk about a conscientious refusal? Well, it's one of these cases where a provider is saying they do not believe in the ethical acceptability of what a patient is asking them to do, and they thereby do not provide the care, right? Now, when we're talking about conscience, I think that they give us a nice definition in the ACOG committee paper, and it's the private, constant, ethically attuned part of your human character. Oftentimes it translates to something like this. It's your conscience guiding you when you say something like, if I did X, I would be unable to live with myself, or I would be unable to sleep at night. And in this way, when we're talking about conscience, when you act against it, it's going to feel like self-betrayal or a situation where you feel like your personal integrity is being violated in doing that thing. Now, ACOG notes that some claims of conscience might not be genuine, right? So if a person is refusing to provide a certain kind of care because they find a certain kind of procedure to be inconvenient or unpleasant, or if the person is simply scared of external criticism, these are not genuine claims of conscience. The genuine claims of conscience are more closely attuned to a person's identity, the amount of emotional distress that they would personally feel from having done something. So, we might see the healthcare provider saying, look, it would be a violation of my morals, my character, my values, if I were to, say, provide a certain drug or to participate in the provision of a surgical abortion. Now, ACOG has told us that we've gone too far with conscientious refusal in cases like these four. But we should also notice that ACOG is not saying that conscientious refusal is always a bad thing to have in healthcare. In fact, conscience is a really good thing. You want a healthcare provider with a conscience. Oftentimes that's going to be the thing that motivates them to put in the extra hours to care for their patients. It's going to be the thing that makes them speak up when certain policies are impacting their patients negatively. And in this way, we can say, look, conscience is a thing that helps providers do their jobs right. And we should also notice that if we can accommodate the conscience of healthcare providers, we should. So to take a really simple example, one that you may have heard discussed, is sometimes you have a provider who, maybe on the basis of their religious views, does not provide contraception. So for instance, this might happen among pharmacists. And what might happen in this kind of situation is if they receive a prescription for, say, oral contraceptives, but they have a problem of conscience with providing oral contraceptives, they might simply pass the case off to the other pharmacist working with them on staff. And in that way, it doesn't harm the patient greatly, and it allows the pharmacist, in this case, to also protect their conscience. So in that way, we would say, look, when it's possible, conscience is a valuable thing, so we should respect it whenever we can. Right? Now, whenever we can, that's the tricky part, because we also have to talk about limits, right? And maybe one way that we can think about this is conscience is a valuable thing, but according to ACOG, they might say it's a prima facie value. So when respecting conscience is the only consideration that we have to take into account, then yeah, respect people's conscience, absolutely. But ACOG is going to say, when we start to get conflicts between a provider's conscience and the interests of a patient, ACOG says at that point, we have to stop giving accommodation to provider conscience and give priority to patient interests. Here's how ACOG puts it in their committee opinion. They say, by virtue of entering the profession of medicine, physicians accept a set of moral values and duties that are central to medical practice. Now, here are some of the values that come through. One is respect for autonomy. Right? We've been learning about respect for autonomy by looking at cases like DAXs, but also by thinking about when we should even maybe respect the autonomy of patients who are minors. Right? And one thing that comes out of this reflection on respect for autonomy is that it's important for a provider to not impose their beliefs on a patient. So we might think of it in these terms. It may be the case that a provider knows that in their heart abortion is wrong to them. But it's not their job to stop a patient who's trying to receive a legal abortion from getting one, right? And why is that? Well, it's because we are all autonomous individuals capable of making decisions for ourselves. Right? And part of this means a provider needs to provide patients with complete and accurate information. So, for instance, we would not want a provider giving biased or partial information about the nature of something like abortion or intrauterine insemination based on their preferred sources which have not been vetted by the profession. Right? ACOG is also going to say that when we're talking about conscience, we have to make sure that it's giving a provider the option to not do something, but not imposing your beliefs on others says that you can't say, well, out of complicity, I'm not even going to refer you to somebody who will provide you with what you want. So in those cases where a provider is not comfortable providing the kind of care a patient is asking for, a referral is necessary. And ACOG is going to say it doesn't make as much sense to say, well, if I provided an abortion, I wouldn't be able to live with myself. They say that makes sense, but it doesn't make sense to say, if you receive an abortion, I wouldn't be able to live with myself. ACOG says that sort of appeal to being complicit simply through referral is not a genuine claim of conscience. So beyond respect for autonomy, ACOG is also going to be concerned about what we might call a fiduciary duty to protect patient health. Fiduciary is kind of a fancy word, but we might think of it in terms of simply being a professional obligation based on a client's trust that the professional is going to promote the client's best interests. In fact, the other context in which you might hear the word fiduciary is in the context of finance, right? So if you have a financial planner or a stockbroker working for you and they say they are a fiduciary, that basically means that this financial expert has a certain number of obligations to not make certain kinds of risks with your money, right? So whether in finance or in healthcare, when we're talking about fiduciary duties, we're talking about obligations within the profession that are put in place so that clients can trust these professionals who are working for them, right? So ACOG says you sign up for certain duties that are just built right into medical practice. Well, we can talk about the fiduciary duty to look out for your client's best interests. And the concern here is that in the 4 cases that we saw, for instance, we are not doing what's in the client's best interests, say when they want to receive emergency contraception, are refused that contraception and don't get access to it, and then have to go through all the difficulties involved with procuring an abortion. So we're going to say this fiduciary duty is going to beat out the value of conscience. Here's what ACOG sees as a violation of fiduciary duties. Here's one case. In religious hospitals, oftentimes Catholic hospitals, we learned recently about Pope John Paul II's views about the sanctity of life. Well, one part of that view is an opposition to providing birth control to patients. And as such, at a Catholic hospital, they do not offer not only contraception in terms of oral contraception, but they will also not provide contraceptive surgeries, whether vasectomies for males or tubal ligation for females. And here's a situation where this might raise a problem. At some Catholic hospitals, they will refuse to provide a patient with tubal ligation, that is mechanical sterilization of a patient, along with their C-section. So if a baby is being born by cesarean section, while the patient is cut open, there is easy access to the woman's fallopian tubes, and it is an uncomplicated opportunity to provide a patient with contraception. So some women, when they know that they're having their last child via C-section, will ask for tubal ligation after the child is born, but before they're sewn up. ACOG is going to say this is a failure of fiduciary duty, because if this mother has to go back and receive another surgery to become sterile, that is going to open her up to more harms and more risks and just more inconvenience and pain if she is refused what she is asking for. So in this way, ACOG is seeing a harm to patients or a failure to benefit patients when we have conscientious refusals. So in this way, ACOG has an objection to the way that sometimes religiously affiliated hospitals will refuse to provide certain kinds of care on the basis of conscience. Another thing that ACOG notes, and I think that this is central to their view, they're going to say that fetal well-being is secondary to the well-being of the main patient, that is, the pregnant person. So, although most of the time, when there is a problem for the health of the fetus, it's also a problem for the health of the mother, and vice versa. But in cases where, say, protecting a mother's life might come at the harm of the fetus, ACOG says the main patient is the pregnant person, not the fetus. And in that way, if there is one of these rare conflicts, the fiduciary duty to protect patient health is going to treat fetal well-being as secondary to the well-being of the pregnant person, who is the main patient. Just a couple more points on the limits of conscientious refusal. They point out that conscientious refusals must be in line with scientific integrity. So an important one, and it ties back to the first two examples that we started with, it involves not using mistaken or controversial science as a basis for one's refusals. So ACOG says within reproductive health care, you cannot refuse to provide emergency contraception on the grounds that emergency contraception is what is called an abortifacient. An abortifacient is a pill or a drug that causes a pregnant person to miscarry. So it's an abortion-causing drug. ACOG points out here that a drug like Plan B does not prevent the implantation of a fertilized egg, nor does it end a pregnancy that is in process. So, insofar as people object to Plan B on the basis of it causing abortion, ACOG says that is an unacceptable refusal because it's a refusal that's based on a scientific falsehood, or at least scientific misinformation. The best evidence that ACOG can find says that once an egg is fertilized, a drug like Plan B will not prevent a person from becoming pregnant. They also point to research that suggests that abortion does not cause breast cancer. Right? That is what the best scientific information is saying, according to ACOG. And as a result, a provider who conscientiously refuses to provide an abortion cannot use breast cancer as a reason to refuse to provide that care. They also note that we should also be very mindful of what they say are matters of justice. So in terms of distributive justice, remember this is justice about who has access to which resources and benefits in society. Well, we cannot refuse care to women, especially in resource-poor areas, and especially where getting alternative care would be prohibitively difficult. So we say we might respect a provider's decision to refer a patient rather than provide something themselves. But if we realize that getting alternative care is not an option for the patient, ACOG basically says in those sorts of situations, a provider should check their moral objections at the door. Right? So if it's known that a patient has no other way of accessing emergency contraception, as it seems to have been the case of that 42-year-old mother in Virginia, if she could not get access any other way, then in that case, the compromise should be made by the healthcare provider with the objection and not the patient. Because there are many cases where getting alternative care is prohibitively difficult. Some people hardly have the ability to get time off work or even just get themselves to a particular doctor's office. So when we note these things, that's an extra reason to provide the care in spite of the provider's conscientious refusal. They also note that some refusals of care, even if a referral can be done, could be deeply insulting. So this would tie back to refusal to give fertility or just reproductive technological care to a same-sex couple, even if they could get the care somewhere else. Telling LGBTQ people that they should not receive care because they are unfit parents is in itself an injustice in the way that it's deeply insulting to these people. And as ACOG puts it, well, it's true that providers can't fix all of the problems of inequality in society. They do have an obligation not to create or reinforce racial or socioeconomic inequalities. So, what are the practical implications here? Well, here's what ACOG says. We'll read a lengthy quote. Individuals and institutions should support staffing that does not place practitioners or families in situations in which the harms and thus conflicts from conscientious refusal are likely to arise. What does that mean? Well, for those who feel it improper to prescribe emergency contraception should not staff sites, such as emergency rooms, in which such requests are likely to arise. And prompt disposition of emergency contraception is required and often integral to professional practice. Similarly, institutions that uphold doctrinal objections should not position themselves as primary providers of emergency care for victims of sexual assault. And when they do present, they should be given prophylaxis. So, one thing that we'll note is if you are likely to encounter emergency situations where people are asking for things like emergency contraception, well, in those sorts of situations, if you are not willing to provide the care that's going to emerge in such emergencies, you should not be in that job. That's basically ACOG's view. They're also going to say, if we have a sexual assault victim, they simply should not be taken via ambulance to a hospital that will not provide contraceptive care. And in the cases where a patient needs prophylaxis, something like emergency contraception, they should be given that emergency contraception, is ACOG's view. Now, in one way, we might say this is an approach that simply puts patients' interests first. But we might note, this is for providers who have certain views of conscience, we might say a big ask. Should we oppose those opposed to emergency contraception from working in ERs? Should it be the job of the scheduler to make sure that there is at least one person on the staff at all times who's willing to provide emergency contraception? And should religious hospitals be required to not take sexual assault victims or be required to provide emergency contraception? Like, have it ready just in case, in spite of the fact that this hospital has conscientious and doctrinal objections to such a practice. So, this is the challenge, right? In a certain way, ACOG is saying, if you're not willing to provide patient care, then you should not be working in certain kinds of jobs. And as a healthcare provider, you might be required to do things that even go against your conscience sometimes. Now, I'll leave it to you as a question of reflection. Is this a reasonable approach for a professional organization to be taking? Or is this a stance that may well exclude certain people from professions like obstetrics and gynecology? I'll leave it to you to think about that. But thanks for listening along and thinking. Today we talked about this really interesting position paper by the American College of Obstetricians and Gynecologists. So thanks for listening in. Take care.